Hospitals are under increasing pressure to discharge patients earlier and earlier. We all know that the longer patients are in the hospital, the more likely they are to develop complications. Further, CMS requires that hospitals develop a discharge plan responsive to each patient's needs and reassess this plan on an ongoing basis. Given the ever shorter lengths of stay, problem identification, care planning, and discharge planning ideally begin upon admission and require a team approach. The optimal time for such planning is during morning huddles. At a minimum, huddles should be attended by the patient's primary care nurse, the unit lead, the care coordinator, and the social worker. If possible, the patient's physician should also be in attendance. Each brings to the table a unique set of skills which, when combined with the skills of others, enhances patient care. To be most effective, all huddle participants should come prepared. Doing so improves communication and eliminates wasted time. A huddle agenda has been developed by nursing to help ensure that all the information needed to optimize the huddles is available. This same agenda can also be used for shift-to-shift handoffs so that all pertinent information is available for each shift. A properly run huddle will save everyone a lot of time. Let's briefly review this in more detail. Everyone attending the huddle should of course know the patient's name, attending physician, and date of admission. Generally, the first to report is the patient's nurse who, with help from the lead if needed, quickly presents the patient's principal diagnoses, treatment plan, and anticipated length of stay, both the date and the day of the week. This ensures everyone is working toward the same length of stay goal. If the length of stay goal is not known, the nurse should offer her best estimate based upon her past experience caring for similar patients. Next, the team should identify the patient's discharge destination and any potential discharge barriers such as an IV, Foley, inaccessible home, or lack of family support. After identification of any barriers, the team needs to determine how and by whom each barrier will be removed. The team should also identify any factors which might lead to readmission. Remember, a boost score greater than 7 generally identifies those patients that are at the greatest risk for readmission. Any risk factor for readmission, for example poor social support, should be identified and assigned to the appropriate person for management. The team should also ensure that the patient has received appropriate education and, when appropriate and indicated, that the family has been in for training. Patients requiring home health should be identified as soon as possible, and the home health liaison should be called. It is not best practice to wait until the day of discharge to contact home health. If equipment or supplies such as a walker, wound vac, or home IV are needed, they should be identified and ordered. A specific follow-up appointment should also be made prior to discharge. Historically, unless we have scheduled this appointment, we not uncommonly readmit patients who have not yet been seen by their primary care physician following their last admission. Finally, all Medicare patients should be given their Medicare letter. To follow are several video examples of morning huddles.
Miss Sweetheart in room 250, 65-year-old woman admitted with CHF 2 days ago. She's also diabetic and hypertensive. Doctor is Dr. Curry. This is her third admission for CHF this past year. She's getting IV Lasix. She has a Foley. We're trying to get out of here in 2 days. She also has multiple meds. She's depressed. She's got poor social support. I'm worried about her taking her meds at home because she lives at home by herself. So her lungs are clearing. She's ambulating by herself. Diabetes under control, but she still is hypertensive.
Okay, I talked to her and the son yesterday, and she's probably going to go home with home care. She has a really helpful neighbor, or they might look at assisted livings for the future. She has all her diabetic supplies, glucometer, strips, everything, and she does pretty well with that. But she is CHF, so we'll make the care transitions and home care referral.
Okay, perfect.
And yeah, and we'll look at some, I was going to give her some support group information for the depression.
Oh, that'd be great.
That would be really good.
Okay.
You know, she still's got her Foley in. We need to ask Dr. Curry about getting that out.
Okay, and I'll also ask her to look at her blood pressure and get her started on some new meds.
Okay. How about follow-up appointment?
Do you want me to make that?
That would be great, yeah. That'd be
Okay.
All right, I'll make that, and then I'll make sure to write it in the notes so that everyone will know. And
okay.
I'll print it out and give it to her, too.
Okay, perfect.
And Ray, what about her education? Have you done any work with that?
Yes, heart failure booklet has been given, and she is receptive to the teaching, and I will keep reiterating it.
Okay.
If you notice that she needs any other diabetic supplies. She's got really good insurance.
Okay.
So we could get a new meter, or if she doesn't have enough strips or Lancets, she's got insurance that would cover that.
Okay, I'll ask her. I'll check, yeah.
And I noticed she's Medicare, so we want to make sure we get her the letter.
Okay.
Okay?
Okay. Sounds great.
Great, thanks.
Thank you.
Okay, I have Mr. Cohen. He's 78 years old, and he's in room 172, bed 2. He was admitted last night through ED with a right fractured hip and roll-out head injury. He did fall at home where he lives alone in a trailer. He's been on dialysis for several years. Brain CT was negative. The plan is he's going to go to surgery in the morning for his hip. His baseline is that he is pretty independent. He is on dialysis Monday, Wednesday, Friday at FMC. He had it yesterday. I think at this point, the plan is surgery, continue with the dialysis piece, and also post PTOT evaluation so that we can anticipate his length of stay, maybe 3 days, and he could go hopefully to a sniff on Friday.
Great. When you talk to PT, could you let him know he's a dialysis patient so they can check to see if he's going to be able to sit in a dialysis chair for 3 hours?
I will.
Okay.
I'll start a sniff search. He may be able to go to our rehab unit if he qualifies. He's got Medicare and a supplemental plan, so that's good insurance to cover his rehab.
Do you see any other barriers to discharge?
Not at this time, depending on the dialysis component, and if we can go with PTOT's eval.
And do you know if he has any family or support in town?
I'm not aware of it at this time. I know that he has a close friend, but I will check with him and get back to you.
Thank you.
He was admitted last night, so tomorrow he'll need the Medicare letter signed.
Okay, I'll check on that too.
Thanks, Michelle.
You're welcome.
To summarize, as you can see, the Discharge Huddle is critical for planning care and removing barriers to discharge for our patients and their families. Per CMS requirements, hospitals must develop a discharge plan for all patients and reassess this plan on an ongoing basis to meet patients' needs. Discharge planning begins at admission. At St. Joseph Health, Sonoma County, planning and preparing for discharge begins at admission. A collaborative team integrates information from the patient and family and all members of the care team. Key points to remember. All discharge planning needs to be documented. Discharge huddles are held daily on each unit. At Santa Rosa Memorial, patients' primary nurse is responsible for presenting their patients at huddle. At Petaluma Valley, the lead nurse presents the patient at huddle. Please utilize the Patient Hospital Course Intervention to provide a summary of the patient's barriers to discharge. Use Recall to document and update patient information each shift. This is an example of the Patient Hospital Course documentation. There are discharge requirements for all inpatients. Every patient needs to have a follow-up appointment scheduled with their doctor or clinic before they leave our facility. All heart failure and COPD patients need to be referred to Care Transitions and also to home care. Care Transitions is in development at Petaluma Valley. The Medicare letter must be given to all Medicare patients within 48 hours of discharge. This is done in collaboration with care management. Please remember, the Patient Hospital Course is a tool to help prepare the patient and family for a safe discharge. Further, the Discharge Huddle creates the opportunity to collaborate with the patient's care team to coordinate care and remove barriers to discharge for our patients and their families.